Good evening. It is just after 6 p.m. Central Standard Time, so we are going to get started. First and foremost, it is a pleasure to be with you tonight and to be joined by my co-moderator, partner, and friend, Dr. Corrigan McBride. Welcome to all the viewers to Bariatric Surgery for the General Surgeon webinar, and thank you to our panelists for spending time with us this evening. We hope that this webinar provides the audience with a basic understanding of some of the complications that can occur following bariatric surgery, in addition to suggestions for basic workup and temporizing of bariatric patients who may be experiencing any of the issues discussed in this webinar until subspecialty care is available. Just a few housekeeping items. As a reminder, this is part of the SAGES webinar series. SAGES is the Society of American Gastrointestinal and Endoscopic Surgeons, and is an organization that truly has a niche for anyone interested in becoming a member. In addition to the listed membership benefits, SAGES has several important values, including the unofficial value of fun within the organization and amongst its members. There are several different membership types based on your level of training, and we encourage anyone listening to this webinar who is not a current SAGES member to go to the SAGES website to learn more about your potential involvement in the society. As a reminder, the SAGES annual meeting is around the corner and is currently planned to be an in-person meeting. Thank you again to SAGES for sponsorship of this webinar. And with that being said, let's get started. What I already love about this webinar is that I am personally connected to each of the speakers, and I am honored to hear each of them share their expertise with us tonight. We're going to move through the speakers with an opportunity for questions and discussion after all the speakers have given their talks. We encourage you to use the question and answer option to submit your questions ahead of time, so that they are not forgotten as we transition between the speakers. First up is Dr. Julietta Chang, who is a bariatric surgeon at Marion Regional Medical Center in Santa Maria, California. She'll be discussing small bowel obstructions and internal hernias following bariatric surgery.
Hi, everyone. Just a second to share. Okay, hi everyone, I'm Julie Chang. I'm a bariatric surgeon at a community hospital in Santa Maria, California right now, and I'm going to be joining the Kaiser team in Bellevue in a couple of months. I want to thank SAGES for organizing this opportunity to share with you guys today, and also for Dr. Haskins and Dr. McBride for chairing this event. I'm going to be talking about internal hernias and small bowel obstructions in the bariatric patient. I still don't have any disclosures. So today we're going to go over a few things. We're going to talk about how the epidemic of obesity is increasing. And as a result, there's an increasing number of patients undergoing bariatric surgery. We're going to review the two most common bariatric procedures that are performed in the United States. We're going to go over small bowel obstructions, their etiology, specifically internal hernias. And I'll talk through a couple of surgical pearls that I've kind of picked up over the couple of years. So as we all know, there's an increasing incidence of obesity. In the United States, it's up to 40% of adults with obesity. Bariatric surgery remains the most effective treatment of both obesity and its comorbid conditions. And currently, about 250,000 patients a year are undergoing bariatric surgery. So given the increase in the prevalence of obesity, as well as the number of patients that are undergoing bariatric surgery, there's an increased likelihood that the general surgeon is going to encounter a bariatric patient. And ideally, these patients would be managed by their original surgical team, but sometimes this isn't realistic or logistically possible. The gastric bypass and the gastric sleeve are the two most common bariatric procedures done in the United States today. The bypass is the more established operation, and there is a lot of literature discussing how it is a very effective treatment for both obesity and its comorbid conditions. In terms of the gastric bypass anatomy, we divide the most proximal portion of the stomach from the fundus and the majority of the parietal cells. And then about 50 centimeters downstream from the ligament of Treitz, the small bowel is divided. that distal half is reanastomosed to the gastric pouch so that it has something to empty into. And then the small bowel is reconnected downstream. So when patients eat food, it comes down into their gastric pouch, down their roux limb, and the biliopancreatic secretions meet with that food downstream. The sleeve gastrectomy is the most common procedure performed in the United States today for bariatric surgery. It's a newer procedure, and it's as you can see from this diagram, because the procedure is just performed on the stomach and the small bowel downstream is left unaffected. Patients who present with a bowel obstruction after a sleeve gastrectomy can essentially be managed like a patient with a normal anatomy. And because of that, I'm going to be focusing mainly on small bowel obstructions after a gastric bypass because the anatomy is more confusing and it is also a lot more common. So bowel obstructions can occur at any time after a gastric bypass in the acute period after surgery or decades after the index surgery. The lifetime incidence, depending on the study, can range anywhere from 3 to 5%. And these patients can present with acute onset symptoms or chronic symptoms that are more vague. The overwhelming etiology for an obstruction after a bypass is an internal hernia, but it can also be due to other causes, things like adhesions, abdominal wall hernias involving bowel, or intussusception of that small bowel anastomosis or the jejunojejunostomy. So a small bowel obstruction in a bypass patient warrants a little bit more panic than in a normal anatomy. There's 3 different GI tracts that can be affected: the roux limb, the biliopancreatic limb, and then the distal common channel. The remnant stomach is a blind limb, and untreated obstruction can cause blowout of this remnant stomach, which can be catastrophic. In terms of the anatomy of the most common cause of bowel obstructions, aka internal hernias, there are 3 potential places where a bowel obstruction can occur potentially. So the most common area where you would see a bowel obstruction is this bottom arrow, which indicates the mesenteric defect that's created between the jejunojejunostomy. In older bypass patients, they may have a retrocolic roux limb, where this roux limb actually goes through the mesocolon of the transverse colon. That defect itself can cause an obstruction, as well as the space behind the roux limb, between the roux limb and the colon. And that's called a Peterson's defect, and it can cause an obstruction in a patient with either an anticolic roux limb, as pictured here, or in a retrocolic roux limb. So a patient with an internal hernia or a small bowel obstruction generally tends to present with epigastric or left-sided abdominal pain. And their exam can be fairly impressive or unimpressive depending on how severe the obstruction is. The vital signs usually show just a mild tachycardia. If a patient does have a sustained heart rate over 150 beats per minute, that should immediately raise your suspicion for a gastrointestinal leak. In terms of what you would find on blood work, you may see a mild leukocytosis. If you do see an elevation, a transaminitis, or an increase in amylase, this should raise your concern that the BP limb or the biliopancreatic limb is involved. If these patients undergo imaging, you may also see that classic swirl sign where the mesenteric vessels are twisted in the setting of an internal hernia. And if the biliopancreatic limb is involved because the obstructions at the common channel, et cetera, then you would also see a very dilated remnant stomach. Here is a diagram demonstrating that swirl sign here. You can see the actual mesenteric vessels that are swirling. This particular cut just shows relatively non-dilated loops of bowel. And here's another one where you can see the swirl of the mesenteric vessels in some dilated loop. So in terms of diagnosing these internal hernias or bowel obstructions, if you see that finding on a CT scan or make that diagnosis on imaging, then obviously the patient should go to the operating room. However, these CTs can be normal in anywhere from 20 to 50% of patients, depending on the study. And so if the patient has a normal looking CT but persistent symptoms, they should be taken for a diagnostic laparoscopy because the sequelae of missing a bowel obstruction or an internal hernia can be catastrophic. So in these patients, even if the roux limb or the common channel is a point of obstruction, an NG2 placement is not recommended. In these obstructed patients, the roux limb can be very dilated and thin-walled, and you can cause a perforation. In addition, the biliopancreatic limb is a blind limb, and this would not be decompressed by the NG2. And so these patients should be taken to the OR. In terms of operative considerations, laparoscopic approach is acceptable based on a few different factors. The first being, surgeons' comfort in terms of managing this difficult anatomy, their ability to be able to do suturing inside of the abdomen. And if there's anything confusing about the anatomy, or if the surgeon would rather do these anastomoses or resections extracorporeally, then they should not hesitate to convert to laparotomy. In addition, if the preoperative CT scan shows massively dilated loops of bowel, that's concerning for lack of adequate working space with insufflation, then these patients, it's reasonable to start these patients open as well. And lastly, patient factors, including, if they're unstable, consider laparotomy. Again, that massively dilated bowel on preoperative imaging. So in terms of different tips, with laparoscopic access, it depends on the surgeon, but I most commonly go in the left upper quadrant. However, that's usually the area where all of the obstructed bowel and dilated bowel ends up. And so in these cases, especially if the CT scan very clearly shows a lot of dilated loops of bowel in this area, instead of going at Palmer's point, I may go with the right upper quadrant. The anatomy, once you do enter, can be very confusing. And instead of addressing like the tangled knot, the easiest thing to do is just find the decompressed terminal ileum and start working your way backwards. And once you do that, with an internal hernia, it will untwist on its own. If it's not possible to do this laparoscopically because of bowel edema, making it hard to grasp the bowel, causing serosal tears, or if there's adhesions that are preventing you from untwisting the bowel, then you should convert to laparotomy. And also, after you're done, you'll look at the bowel, see whether or not it's viable, resect and reanastomose if needed. Always definitely close the defect that you found the bowel in and use permanent suture. Another thing to consider is if there was a lot of involvement of the biliopancreatic limb and the remnant stomach is very dilated and it's not decompressing by the end of the surgery after everything's been untangled. I have put in a venting G2 in these patients just to make sure that there's no risk of a gastric leak from the stomach emptying slowly after this obstructive episode. And so, like I mentioned multiple times before, because there are multiple limbs after a gastric bypass, it's not completely possible to decompress the GI tract with something like an NG tube alone. And we have all these things like time is heart muscle or brain for heart attacks and strokes. But in these bypass patients, time is really bowel. And there are, I've seen patients who end up with short gut syndrome because of the amount of bowel that's been involved that ended up necrosing. And so the bottom line is, if the patient is acting obstructed or if they have this chronic pain, even if the workup is completely normal, they should be taken for a diagnostic laparoscopy. Another thing that I do want to mention, a special population, are pregnant patients. After bariatric surgery, patients tend to have increased fertility because they approach a healthier weight. And so we end up seeing a lot of patients with a history of bariatric surgery who are gravid. And in these patients, I find that if they do develop an internal hernia, it's because the gravid uterus actually pushes all their bowel up and seems to cause a hernia through the Peterson's defect more commonly than through a mesenteric defect. In these patients, OB-GYNs may be reluctant to do something like a CT scan. MRIs, in my experience, are worthless. They don't really show anything. And so, as I mentioned before, if the patients have persistent symptoms, even if it's just colicky abdominal pain, they should be taken for a diagnostic laparoscopy, because the risk of that is much lower than the risk of missing a hernia, potentially having dead bowel on both mom and baby. If the patient is very close to term, then there's really not going to be any room to work laparoscopically. And so you should discuss with the obstetrics team about whether or not it would be feasible to do a C-section at the same time via a lower midline incision, and then you can explore the bowel at that time. In terms of post-operative management, for patients who have been operated on laparoscopically, they can generally be started on a liquid diet and discharged once they're tolerating. And for patients where you place a decompressive G-tube, this can be capped once your output decreases by whatever metric you generally use, and removed in office after 4 to 6 weeks. Thank you for your time. And one last note, even after these defects have been fixed, they can recur either due to weight loss and loss of mesenteric fat, the sutures pull through. And so if a patient presents with recurrent symptoms after this has occurred, it should not lower your suspicion necessarily that the patient has an obstruction caused by something like an internal hernia. Thank you very much.
Thank you so much for that, Dr. Chang. Moving right along, next is Dr. Mackenzie Landon, who is a bariatric surgeon at the University of Arizona Banner University Medical Center in Phoenix, Arizona, where it's 75 and sunny. I'm very jealous. She'll be discussing GJ perforations and marginal ulcers.
Thank you, Dr. Haskin. Thanks, Dr. McBride, for having me this evening. I am going to be sharing my slides. Give me 1 second. Okay. Additionally, I want to take a second to thank my co-panelists for participating on this with me. This is a topic near and dear to my heart as a bariatric and metabolic surgeon. So it's always nice to get the word out about how to manage some of these patients. Additionally, I want to thank SAGES for the opportunity to speak on this topic as well. So I'm going to be talking about what I call the difficult gastrojejunostomy. I have no disclosures. The objectives for our conversation for my part is going to be talking about both acute and chronic issues, acutely considering ulcerations, bleeding GJs, and perforated GJs, as well as chronic issues like persistent non-healing ulcers and strictures. So GJ issues matter because bariatric surgery is not going away. We have already discussed in Dr. Chang's lecture, and I suspect other panelists will touch on this as well, but the incidence of obesity is increasing by year, and as such, the number of procedures are also increasing, especially when we're seeing improved insurance coverage at various locations. There will be more patients that will be undergoing these operations with time, and therefore these are problems that will only continue to become more relevant. We know marginal ulceration is a common complication following gastric bypass, and therefore it's appropriate for all surgical providers to be familiar with the pathophysiology and how to manage these patients. So touching on a little bit about the gastrojejunostomy, as was mentioned previously, we create a small gastric pouch. Most of the literature cites a size of between 15 to 30 cc's. The goal here is to make the pouch smaller in size to reduce the chance of ulcer formation by excluding as many parietal cells as possible. And then having an anastomosis that ranges from 20 to 30 millimeters in size. Again, that varies by location and technique. And the main perfusion of this pouch comes from the left gastric artery, which is carefully preserved at the time of its creation. We know that if there's tension on that anastomosis, or if the artery is compromised during dissection, that people can develop ischemia of the anastomosis itself, which can cause an acute bleed or leaking. So careful technique is performed for this part of the procedure. Ulcers have a variable incidence, and the reason for that is it really depends on how they are diagnosed. We suspect there are a wide variety of patients are walking around with ulcer disease, but if they're asymptomatic, it's not something we're going to be able to diagnose for them. So most of the time, the numbers for ulcers really come from the patients that have had an endoscopy due to symptoms. Ulcers typically start on the jejunal side, and if they're large enough, we'll be able to see them on the gastric side of that anastomosis. As I mentioned before, they can be caused by technical issues, but they can also come from different exposures like NSAID medications, steroids, nicotine, and even immunosuppression has been documented as a cause for ulcers. The thoughts for the mechanism of action for some of these medications is that we're inhibiting the production of prostaglandins, resulting in a disruption of the gastric mucosal barrier. And some thought there is if there's no protective mucosa, the acid has no opponent to irritating that mucosal tissue. Additionally, there's some thought that NSAIDs can increase the risk of GI bleeding by blocking the production of thromboxane A2, which is involved in platelet aggregation. And when we're looking at the presentation of ulcers, there are a wide variety of presentations. Most of us have seen patients that have presented with pain. It's usually in the epigastric location, and it's described as being constant and worse with meals. For patients that might not necessarily have pain, they can present with bleeding in the form of hematemesis or melena. And oftentimes those can present as a sentinel bleed. You might get a triage call from a patient who's had surgery that has had dark stools for the past day or so, or patients who had a single episode of, coffee ground emesis that represents their sentinel bleed prior to a major hemorrhagic event. Additionally, ulcers can also present as a perforation. Typically, the presenting signs and symptoms of this are severe pain and tachycardia. If the perforation has existed for time long enough to present itself as fever or peritonitis, these can also be seen. In patients who have an ulcer but do not have bleeding or perforation complications, again, as I mentioned, these are frequently diagnosed on EGD. The treatment for this would be to remove the inciting source. If a patient is smoking, they must stop. If they're taking Motrin for knee pain, that also has to end. We can put them on twice daily PPIs with Carafate as sort of a mucosal barrier and as an acid suppression. And some institutions are also using misoprostol to help with modulating those prostaglandins. Dietitian support is crucial. People need protein to be able to heal this injury, this wound. So any patient that's diagnosed with an ulcer should be seen by a dietitian that is experienced with bariatric surgery to provide the correct protein needed to heal this. And then whenever I have someone diagnosed with an ulcer, I also take that time to check their vitamin labs. Because oftentimes if they're not eating enough to heal this, they're also not necessarily adherent to the recommended vitamin supplementation. In patients that present with bleeds, it really depends on how stable they are or not. If they're stable, you can start with medication, obviously get an EGT to try to figure out if the bleed is ongoing or if it was a bleed that has self-resolved. Various therapies can be performed during endoscopy to get control of this bleed, and they need to be admitted to monitor them for ongoing blood losses. If the patient is not stable, they need to be aggressively resuscitated with massive transfusion protocol and admitted to the ICU. And then there can be a discussion with GI colleagues if they're available to consider emergent EGD for some of these therapies. Or if the patient is at a center where there's a bariatric surgeon that can come in, then we can consider doing a revision or they can be transferred to a bariatric specialist. The goal, though, is to really manage these without doing an emergency revisional procedure, because often those are higher risk of complications than managing it with an endoscopy. If a patient presents with a perforation, typically this is diagnosed on a CT scan that's performed in an emergency department setting, traditionally with oral and hopefully IV contrast as well. And despite diversion of bile from the gastric jejunostomy, they can have significant contamination if the perforation has lasted while they've been eating and drinking. I always recommend you consider early diagnostic laparoscopy for these patients, whether or not there is contrast extravasation, because pain is often very significant and the length of stay can be shorter if we act sooner for these people. Again, some other sources of perforation I wanted to mention. I already mentioned NSAIDs, smoking, and steroids, but H. pylori has also been known to create gastric ulcers, as gastric cancers can also perforate, and patients can also stain perforations in an iatrogenic fashion if they were having, for example, a dilation of a stricture or a biopsy of a polyp or a mass. So things to consider that need to be included in the decision-making process for management. So I'm going to go through my approach for patients with a perforation. And again, this is my singular experience, so I encourage all the panelists to add some comments as well at the end of our session tonight. I typically put in 3 trocars that are 5 millimeters. These are denoted by the smaller X's. This large X represents a 12 millimeter trocar to be able to facilitate passing of the suture. You can use a 5 millimeter trocar and flatten the needle out to be able to move that through. But for ease of movement, if you need a stapler or some other larger suction device, the 12 millimeter works great for this. And then I also put a Nathanson liver retractor up in the epigastrium to retract my liver out of the way. I'm going to cause some controversy by talking about suture choice for closure of perforations. Classically, we think of silks. I was trained with Vicryl. There are several people I know who use PDS to close these. I think the point is close it well and have a plan for if you have a leak. And I'll get to that in a second. I typically leave a Blake drain behind, and I always scope patients while I'm in the operating room with them. So the first move is to identify the perforation. I perform a modified Graham patch where I primarily close the hole with my absorbable suture. And then at that time, I choose to perform an air leak test to make sure that my closure is sufficient. And then I secure omentum over that repair with additional Vicryl sutures. I irrigate the abdomen. While I'm there, I'm going to check for internal hernia defects and close those if I find them to prevent the patient from future complications. And I'm also going to look at the remainder of the abdomen for anything else that's suspicious. The one thing I wanted to say is if you do have a perforated remnant or duodenum, then I would consider leaving a gastrostomy tube. The purpose of that is twofold. You want to decompress that baliopancreatic limb and take the pressure off of your fresh repair. But also, if you need to study that repair prior to, let's say, letting that patient go or removing a drain, having a G-tube in the remnant allows you to do that. It ensures that the duodenum is open, that your repair is solid, and that you can move forward with that patient's care. And then I mentioned earlier about absorbable versus permanent suture. Again, I think it comes down to preference and how you were taught. There is some literature to support that any retained foreign bodies can encourage ulcers to persist. So keep that in mind. And then also there's some thought that if you have a braided suture material that you can retain infectious agents that can also prolong complications. So I'm going to share with you, if I can play this, a CT scan. It's kind of brief, but just showing a little bit of free air around the duodenum. Really subtle, not a lot of free fluid, and no contrast extravasation. This patient was in significant pain, was requiring a decent amount of narcotics. So even though there was no contrast extravasation, not a lot of free fluid, there was air outside of the duodenum, consistent with perf post-gastric bypass, and I chose to take this patient for a diagnostic laparoscopy. See here. So in the operating room, about a centimeter distal to the pylorus, there was a dime-sized hole in the duodenum on the lesser curved side that I then closed, as I described previously, with suture, and I performed an air leak test and then covered it with a patch of omentum. Because this was a duodenal ulcer and I didn't have access to evaluate his duodenum with an endoscopy, I chose to leave a G-tube behind in this patient. And this is the scan of his post leak test scan, if you will. So 48 hours after surgery, I wanted to be able to take his drain out and feel comfortable knowing he doesn't have an obstruction of the duodenum from an undiagnosed cancer or a very large ulcer. So I opted to perform a CT scan here and put contrast through his gastrostomy tube. And it goes all the way to the distal duodenum past my repair. And he is doing great. He's about 3 weeks out from surgery now. So just some tips I found helpful over time is really use your CT scan to identify the main area of contamination and where to start your exploration. Usually these patients have a scan before they get to you. Oftentimes everybody has a scan when they're in the emergency room, but use that CT scan as a guide. In this video here, there's a decent amount of free air anteriorly, and you can see this angry looking roux limb coming into view. And just distal to the GJ on the anterior surface of the roux limb, there was a perforated ulcer that needed to be addressed in that patient. When you're in the abdomen, the omentum and the fibrinous tissue are really your guides to where the problem is. The omentum is known as the silent policeman and will travel to wherever there's injury. So if there's an area where there's a lot of omentum densely adherent to something, use that as a cue that there's probably shenanigans below. Additionally, as I showed in the picture earlier, there's a lot of fibrinous tissue and in regions of perforations, and that can be your guide as to where holes might be. If you can't find the hole, don't be afraid to get an EGD and do an air leak test on your own and see if you can find the perforation that way. And then if you've checked the GJ and the roux limb and you still can't find the perforation, check the remnant and see if there's a perforated remnant or a perforation in the duodenum itself. So post-operative steps, this is just an example of the case that I already talked to you guys about, and that I usually leave people NPO for 2 days to let that repair seal. I will consider doing an upper GI versus a G-tube study depending on where the perforation is located. We traditionally here at U of A do liquids and then advance to a soft diet just to let that repair seal up nicely. We'll pull any G-tubes at 6 weeks, and then we always scope everyone 3 months after because we still have to treat the underlying problem, which is the ulcer. So they need to be kept on their PPI and Carafate for that duration and have their endoscopy performed to ensure that it has officially healed prior to you stopping any medical therapy. And then talking briefly about chronic GJ issues, persistent ulcers and strictures. Chronic ulcers oftentimes are from smoking. There's a very significant risk of revision in people who smoke after bypass surgery, as well as risk of persistent ulcers with steroid use. People often complain of chronic fatigue, which can come from anemia from these slow subclinical GI bleeds related to the ulcers. So keep that in mind. If people have these chronic ulcers, they are usually or should be on BID, PPIs, and Carafate. And you have to question whether or not people are following those recommendations. And then additionally, nutrition is always an issue. Oftentimes patients are afraid to eat because of the pain. So that needs to be a part of the treatment strategy as well. Additionally, if we withdraw anti-ulcer medications in one go without an appropriate taper, oftentimes patients will have a relapse in their symptoms and they can have a recurrence of the ulcer. Recommend at this point to taper off the medication in asymptomatic patients after 3 months, and there's really no data to support lifelong prophylaxis. If chronic ulcers persist, we know that if people have cured themselves of a marginal ulcer from your therapy and they have another marginal ulcer, that their ability to respond to medical therapy at the second go is only 1.4%. So these are people that are potentially going to need intervention to treat their underlying problem. And really the time of non-operative or medical management to operative management is pretty variable depending on what study that you look at. And so for patients who've had an ulcer after they've done 3 months of max aggressive medical therapy, start having conversations with your colleagues about what the next steps are going to be if this does not heal, and set a timeline for yourself of when you think that's appropriate based on your institution and the literature you have available. But for us personally, if we have maxed out medical therapy at 6 months to a year after surgery, we're going to have these conversations about whether they should be revised, whether they need to be offered a vagotomy, and other supplemental therapies. Oftentimes that period of 3 months to a year, it's getting these patients compliant with diet and nutrition and medication management. And just for completeness sake, the current definition of an intractable ulcer is really failure to heal or relieve the symptoms and heal the ulcer after 3 months. If patients are not stopping smoking, then that doesn't really apply. Additionally, revisions are not easy and they're not perfect. We know that patients still have symptoms even after they're offered revisions. So do not anticipate that a revision will save the patient from future pain or from future ulcers. We know that ulcer recurrence is still 7 to 10% even after revisional therapy. You are operating on a pouch that has already been made, has already had vascular changes made to it, and it's not going to be the same as a primary anastomosis. And the risks of revisional surgery are higher than a primary bariatric surgery, so that needs to be included in decision making as well. Vagotomy is considered for patients who have persistent marginal ulcers. It's typically offered in people who have quote unquote high risk abdomens, or patients who might have had prior open surgery, or people whose pouches are very small and there's not enough gastric mucosa left to sew to. In prior studies looking at vagotomies, we have compared patients who've had GJ revisions to those who've had vagotomies, and we found that the complication rates are still high for both, though favor vagotomies. What's most important to note, though, is that patients tend to have symptoms of dysphagia and have issues with food impaction post-vagotomy. So that needs to be considered because that's not typically seen in someone who's had a GJ revision. There is no difference in ulcer recurrence from either modality. So that has to be a part of discussions and decision-making as well. In another study by Dr. Hunter's group, they did see an improvement in symptoms, marginal ulcers, but again, noted the high rates of dysphagia and pain and nausea and vomiting. But in his group, he had better outcomes with no patients having persistent or recurrent ulcers after their vagotomy intervention. And then finally, very briefly talking about strictures. Oftentimes these patients will present with nausea, vomiting, and PO intolerance. Typically, these are diagnosed after imaging is obtained for these symptoms. The best modality to treat this, at least in the first initial stage, is with an EGD to dilate the stricture as depicted in the images on the slide, and treating the source of the stricture. If the patient is smoking, if the patient has multiple ulcer history, the patient has poor nutrition, etc. And sometimes it takes multiple dilations to cure this problem. So don't be surprised if people have to go for 3 dilations to alleviate the stricture. And if strictures are persistent or they recur, then they should be referred to a bariatric surgeon to revise that gastrojejunostomy. And with that, I will end. Thank you so much. Again, I really appreciate the opportunity to speak.
Thank you so much, Dr. Landon. Next up is Dr. Aaron Moran-Atkin. He is a bariatric surgeon at Montefiore in the Bronx in New York, and he will be discussing GERD following bariatric surgery.
Thank you. I'm having a slight, I don't know what happened to my presentation. Give me 2 seconds. Hey. Hello. I would like to thank Dr. Haskins and Dr. McBride for inviting me, and obviously SAGES for organizing this webinar. More importantly, I would like to thank all of you that logged in to learn more about this topic, which is obviously very dear to all of the presenters' heart, because this is what we do. But it's great that you guys have interest in trying to learn a little bit more about bariatric surgery. So I'm going to talk a little bit about reflux in the bariatric population. I don't have any disclosures. My talk is going to talk briefly on obesity and reflux, then what happens with reflux after bariatric surgery and why. And then more importantly, which I think is sort of like really like the main focus of the talk, is going to be the workup of the patient that has reflux after bariatric surgery. And then I'm going to touch a little bit about management options, although most of them are really going to be dealt by the bariatric surgeon, but there's a couple of things that that can be done. Okay, so as we already discussed, and I'm not going to spend more time about this, obesity is a big problem, right? And we do a lot of bariatric surgery every year. Unfortunately, not everybody that qualifies for bariatric surgery or would benefit from bariatric surgery gets bariatric surgery, but that's another topic. Obesity and reflux have been increasing as within the past years, and it seems to be very hand in hand. As obesity has increased, so has the incidence of or the prevalence of reflux. And this study from the New England Journal of Medicine was a questionnaire to nurses, and 22% of the nurses reported having GERD symptoms at least once per week. And when they were grouped by BMI, it became obvious that at higher BMIs, the odds ratio of having GERD symptoms was higher. Not only do we see this, but also when we look at esophagitis in obese patients, the higher the BMI goes, the higher incidence of the patient having esophagitis. So why does this happen? There's an increased prevalence of gastric and esophageal motility disorders in the obese patient. There's a decreased LES pressure. There's an increased incidence of hiatal hernia. This is mostly because of the increased intra-abdominal pressure and the increased intergastric pressure. And as we all know, central obesity is the most important risk factor to develop reflux. So in summary, right, higher the BMI, the higher the risk of reflux. So what happens when we lose weight? Obviously, reflux gets better. Okay, so this happens if we do structured weight loss, but also after bariatric surgery. In patients that underwent gastric bypass, the improvement in reflux symptoms is more significant than other bariatric procedures. But at higher, the more weight that the patient tends to lose, the more significant the improvement is. So we do see that after gastric bypass, resolution of reflux symptoms is pretty significant. It's almost 65%. Resolution of GERD, of pre-existing GERD symptoms after sleeve is not really that significant. And we do see, more importantly, a significant amount of patients that present with new onset reflux. This happens also in patients after duodenal switch. So it's also important to keep that in mind. So we see that in gastric bypass patients, new onset reflux is low. It's about 4%, whereas in sleeve gastrectomy, it's almost 13%. Right. So this is what's happened in the last few years to the bariatric procedures that are being done in this country. We see that sleeve gastrectomy is increasing. So this means that we're going to be seeing more reflux after sleeve gastrectomy, obviously. So why do patients after sleeve gastrectomy have reflux? There's a couple of things that are avoidable and that we all, as bariatric surgeons, try to pay a lot of attention when we're creating sleeves. One of them is angulation or corkscrewing of the staple line. Another thing that happens sometimes is that people, since the GE junction is the part where the leaks tend to happen more frequently, some people tend to shy away from this area and tend to leave a little bit more fundus up there, and that can dilate with time. Sometimes also there's hiatal hernias that are either very small and are not able to be seen because of the fat pad, or sometimes they're ignored. But there's factors that are not avoidable. This is decreased elasticity of the stomach because we're basically creating a tube of the stomach, right? We're destroying part of the angle of His by dissecting this area. And then we're also causing changes in the LES structure and possibly its length and its strength. And what about bypass surgery, right? Large pouches, we already spoke about that, right? We're leaving more parietal cells, so this is going to predispose us to having issues there. Ulcers and all this could factor into strictures and then give us reflux. Again, hiatal hernias, again, same thing. You know, sometimes we don't see them because of the fat that's in the GE junction. Sometimes we see something, but we think that it's not that significant and it's just left alone. And then obviously internal hernias or obstructions can, if they're chronic, can have reflux symptoms. And similarly, the inevitable things that happen after gastric bypass are the same things, right? Destruction of the angle of His when we're doing our dissection and changes in the LES structure. So what should we all do? What should you guys do if you see reflux patients after bariatric surgery? I think there's two things that are very, very central, right? Upper GI and endoscopy. We'll talk a little bit more about that. And then on a case-by-case basis, pH monitoring could be useful, manometry can be useful, and also gastric emptying. I think that one of the important things is that there's a good amount of patients of surgeons that ask me about pH monitoring, and they say that the patient's complaining of reflux, but the pH monitoring is normal, right? And that is very, that happens a lot, and it's something that we still need to consider, right? So we'll focus a little bit more on upper GI and endoscopy, right? The importance of upper GI, I think, one of the important things, as with everything in surgery, all the studies that you're getting, is you need to take a look at the studies, because I can't tell you how many upper GIs I ask for and they're read as normal gastric bypass anatomy or normal sleeve anatomy, and they're clearly not normal, right? So we want to make sure that we're paying attention to the hiatal hernias, right? In this first upper GI, we're seeing a little bit of a hiatal hernia after gastric bypass, not that little actually. Right? Then we're also wanting, right? We want to see this active, the video swallow of the upper GI, right? Because in here, we're seeing a significant amount of reflux, and that's going all the way up to the thoracic inlet, right? And then in this other picture, this is not a video, but we see a very clear angulation of the sleeve. This is probably one of the more common problems that I see after sleeve gastrectomies in patients that are having reflux. And most of these patients will have normal pH studies, because it's not really an acid problem. It's more of a partial obstruction of the outflow of the stomach. In endoscopy, it's important to do the endoscopy. I like to do all my endoscopies. I would recommend you guys also do your own upper endoscopies to take a look, especially at these things, because it's the same thing that happens all the time. I send them to our GI colleagues, and they always tell me like it's a normal sleeve, it's a normal bypass. But that's not what I want to know. I want to know the little details, right? I want to know if there's a hiatal hernia, like in this first picture, right? If there's a stricture in the sleeve, if there's an angulation at the incisura, right? We can see here that this part of the incisura is angled and strictured, right? If we see some esophagitis, okay, that's very important. And sometimes not only that, right? But we want to see the two things together, okay? We want to see the upper GI and the sleeve, because on the sleeve and the endoscopy, we might see that it looks pretty much normal, right? But then when we put that together and we put the upper GI, we see that there's a big, big neofundus, right? This is not a hiatal hernia, right? That it kind of, maybe we could be tricked in the endoscopy to think that there's a little bit of hiatal hernia, but this is a big fundus that was left there, okay? So like I said before, right? The pH monitoring is important, because it's not that important, because sometimes it will be normal. And that doesn't mean that the patient's not having heartburns. This is mostly symptomatic, right? If the patient's telling you that they feel the food coming up to their chest, something's happening, right? So you need to make sure that everything, and then sometimes everything looks normal, right? And they're still having reflux, right? And then those are the the small amount of patients that I think that there is actual lower esophageal sphincter dysfunction, right? And there are a couple of things that can be done in those patients, but I can't stress enough that it is very, very important that all the anatomy should be normal. If you have a little bit of a kink, if you have a little bit of a hiatal hernia, anything like that, then you need to do, you need to go in and fix that problem, okay? But there is some links after sleeve gastrectomy in patients that, that are having reflux. I have to say, not my preferred method of treating reflux, because I think 99% of the times there is some anatomic issue with that sleeve that, that I think needs to be addressed. Okay, but there is some improvement in the studies that in the literature that's out there. Another thing that I sometimes try is stretta, which is radiofrequency energy delivered at the lower esophageal sphincter. The reason why I think this is a more of a doable procedure is because it's non-invasive, it's not surgical, it's just an endoscopy, and sometimes it'll get patients the bridge or symptom improvement enough to avoid surgery. Some of these patients are not really willing to do surgery, and I think this is a good option. So we see very good results, especially this study is in patients that have not had gastric surgery or sleeve or bypass. But there's also some studies in gastric bypass patients that show pretty good results, and also after sleeve patients that also have seen pretty good results. But ultimately, the reality is that most of these patients will need conversion to a gastric bypass. And that is really where the improvement comes. We see that after conversion to gastric bypass, there's resolution of almost 79% at 1 year of reflux symptoms, and at 2 years, 91% of symptoms were improved. So this is pretty significant. So I think this is really the optimal thing. But I think you as general surgeons really should focus more on the workup, trying to see why this is happening, right? Another important thing that that I don't want to miss mentioning is that sometimes there are looped anastomoses in a mini gastric bypass or a SAGE, and there's bile refluxing back. So that's another important finding that we might be able to see when we do an endoscopy. And that's another important thing that needs to be addressed. Okay, so summarizing, reflux and obesity are closely related. Reflux after bariatric procedures is common, more common in sleeves than duodenal switches, and lastly, gastric bypass. There is some improvement of pre-existing reflux after sleeve, but really the important thing is there's a significant amount of patients that have new onset reflux after sleeve gastrectomy. And the workup is key to finding the cause. The things that I think are essential are endoscopy and upper GI, but then we should not forget about doing a pH study, high resolution manometry. We don't want to miss some achalasia or anything like that. And then gastric emptying, because there is some people that will have some gastroparesis. Thank you very much.
So much, Dr. Maraniakin. Next up is Dr. Hassan, who is a bariatric surgeon at Baylor Scott and White Health in Temple, Texas. She will be talking to us about vitamin and mineral deficiencies after bariatric surgery.
Thank you guys so much for the opportunity to present. So can you guys see my slides okay? All right. Awesome. So I'll be talking about vitamin deficiencies and really what you should be looking for a bariatric patient. So these are my disclosures, and they're not really relevant to this talk. So there have been several studies that have demonstrated that obesity has actually been associated with a high prevalence of micronutrient deficiencies. Some of those studies actually revealed that nearly 2/3 of patients had micronutrient deficiencies before even undergoing bariatric surgery. And the most common ones identified were vitamin D, B12, iron, and thiamine. There have been several mechanisms that have been cited as underlying causes for this. One of those things has been some impaired expression of transporter proteins. That's in the case of iron, and that has been attributed to chronic inflammation. And as we know that obesity is a pro-inflammatory state, it's not unlikely that this is a problem. And the other thing too that's been suggested is small intestinal overgrowth syndrome, which again, in the wide population, it's not very prevalent, but it may be in our pro-inflammatory state patient, it may be underdiagnosed. And last but not least, inappropriate eating behavior with patients favoring high foods that have high energy density and that have poor micronutrient content. So bariatric surgery, as we know, and everybody has talked about, it basically induces weight loss and it improves the patient's metabolic profile. Alterations in the GI tract after these procedures heavily influence absorption. Both the restrictive and the malabsorptive alterations in the GI tract have a direct impact on intake, digestion, and absorption of those nutrients. So therefore, the likelihood of a specific nutrient deficiency is directly related to the actual procedure type that the patient has had. But in all the procedures, and as you can see here on the right, all of the procedures, the most common vitamin deficiencies that have been identified to include the gastric band has been calcium, vitamin D, iron, B12, and thiamine. And those are the ones that we're going to focus on today. So vitamin B1 or thiamine is water soluble. It plays a key role in metabolism of carbohydrates and lipids and branched chain amino acids. It's absorbed in the duodenum and proximal jejunum by a carrier-mediated process. Symptomatic thiamine deficiency occurs in up to 49% of patients post-surgery, so it is pretty high. And the most common risk factor for thiamine deficiency is recurrent post-op nausea and vomiting. And it primarily is associated with the restrictive procedures, but it can be seen with patients who are bypassed. And due to the short half-life of thiamine, so it only stays in the body about 18 to 20 days of the actual stores. This thiamine deficiency can actually present pretty early as compared to some of the other vitamin deficiencies. So in the case of a thiamine deficiency, the patients usually present with nausea, vomiting, and constipation. Dry Burberry, which is actually just a polyneurotic form of thiamine deficiency, it actually manifests as the Wernicke's, which is the Wernicke's encephalopathy that we all hear about. And that's a disorder of the actual eye movements. And then the Korsakoff psychosis is actually the anterograde and retrograde amnesia. And that's also associated with gait ataxia. And then together, these two conditions form Wernicke-Korsakoff syndrome. And that is a syndrome that presents with all of the constellation of symptoms that I just talked about, but can also lead to impairment of fine motor skills. And in its severe forms, it can actually present as hypotension, hypothermia, and potentially lactic acidosis. So wet Burberry has to do with cardiovascular associations with the thiamine deficiency. So that usually is cardiomyopathy and cardiac insufficiency. So in terms of lab findings, you're obviously going to have low thiamine levels. But the key in thiamine deficiency, it's kind of like when we talk about trauma. And if you think about, you're going to do a fasciotomy, if you're thinking about it, you really should just treat the patient. So in this case, in less severe cases, you can give oral supplementation. But in the patients that have acute psychoses and Wernicke's encephalopathy, those patients should be admitted for IV therapy. And the other key thing is that you also want to give thiamine first because of the fact that thiamine is related or involved in glucose metabolism, and that glucose is going to be used for ATP formation. You have to actually give that first because otherwise it'll accelerate cell death. And then in the patients that are severely malnourished and are at risk for refeeding syndrome, magnesium, potassium, and phosphorus should also be given. And then obviously, as you replete their thiamine, you need to check their levels. So again, based on their symptoms, you can also continue to check the levels. And then the ASMBS guidelines recommend that they should be checked in at least at 3 months after this, and continue to be checked after that. So B12 deficiency, it's actually the most common cause of anemia following gastric bypass or a BPD-DS. We know that it's important in the development and initial myelination of the CNS, as well as its maintenance. The gastric acid actually helps with B12 absorption by detaching B12 directly from the intrinsic factor. So the risk factors would be definitely those patients who undergo malabsorptive procedures, also those vegetarian patients that do not eat meat or reduce their dairy intakes for the vegans, and then patients who have extreme weight loss, you may be concerned about B12 deficiency. Neurological symptoms for B12 deficiency is usually paresthesias. Patients have numbness in their hands and feet, and then they can also have loss of position sense. And then actually in pretty severe forms, it can actually present as dementia. So in terms of lab values, again, you'll see a B12, low B12 levels. And then you can also check methylmalonic acid, as well as homocysteine. But honestly, the B12 levels will probably be good enough. And then in terms of treatment, you really want to start oral supplementation if it's mild, and if it's pretty severe, then you can do IM injections. And the IM injections are actually superior to the oral intake, so you might want to start with that to get them to normal levels and then transition to oral. And again, you want to check those levels pretty frequently in the first year after surgery, and then annually after that. And then in specific to our bariatric patients, remember almost all of our patients are on PPI, and then those diabetic patients can be on metformin, and that does reduce absorption of B12 from their food intake. So you want to make sure that you look at that in terms of their medications. The other deficiency that's pretty common is folate. It is a water-soluble vitamin, and it functions as a coenzyme in transferring carbons within the cell in an amino acid metabolism. It's a pretty high prevalence, up to 65% of patients post-op, and it is absorbed from the proximal small bowel. Risk factors are really honestly just low intake, and it really can be a marker for patients who are non-adherent with their supplements. And clinical findings are patients who have diarrhea, they will have some anemia, stomatitis, glossitis, and then in those pregnant patients, they can have neural tube defects. So in terms of lab findings, so it's pretty similar to B12 deficiency, except you will find that these patients actually have normal methylmalonic acid. So that's how you can distinguish the two. And then obviously their folate levels will be decreased. In terms of treatment, you want to do the ASMBS guidelines and TOS guidelines recommend oral dosing to achieve high to normal levels, and then continue with a maintenance dose. But you also want to encourage the patients to eat lots of leafy greens, because that also has a lot of folate in it. And then you can check those every 3 months in the first year and then annually after that to make sure that they're actually doing well. In terms of vitamin deficiency, so vitamin D is a fat-soluble vitamin. And so it's actually pretty prevalent, again, as a pre-op diagnosis for patients with obesity, and then also post-op. So up to 100% of patients can actually have vitamin D deficiency. It is absorbed in the proximal small bowel, and it functions as a key regulator for calcium and bone metabolism, as we know. So risk factors for those patients are, again, those patients that have a malabsorptive procedure, and because it is fat soluble, operations such as the BPD-DS, those patients are at higher risk for developing vitamin D deficiency. Clinical signs of vitamin D deficiency would be patients who present with bone pain, proximal weakness, some fasciculations, and then also depression. In terms of their lab findings, patients actually will have a low 25 hydroxyl vitamin D level, and that's the actual preferred lab test. And then the other key component is PTH. They'll actually have an elevated PTH and then normal calcium levels. So a lot of times these patients will be seen by their primary care and get a workup for hyperparathyroidism because their PTH is elevated, and it really is just vitamin D deficiency. And then you can also check the alk phos, which will also indicate bone reabsorption. So that's also a good indicator. In terms of treatment for these patients, so you can either do weekly or daily treatments. And so the actual daily treatment is actually much better in terms of getting their levels up. But the vitamin D3 is actually more is actually recommended more than the weekly treatment. Okay. With respect to calcium, so a lot of patients will get calcium workups for calcium deficiency. It's actually pretty low in bariatric patients. It's only about 10% of patients. Again, we know that calcium is important in terms of formation of bone mineral and regulation of enzyme activities. And it also functions within a muscle contraction and clotting. So again, it's pretty rare to actually have a calcium deficiency. A lot of times patients will actually have vitamin D and not calcium. And then those patients that actually do have this, those patients that actually have it, most of the time it's a pre-existing condition. And then also they've undergone some sort of malabsorptive procedure, such as a BPD-DS or a bypass, or they're just not taking their calcium supplementation. And that's the other common one. In terms of clinical findings, those patients will present with symptoms of hypoparathyroidism, so paresthesias, muscle cramps, as well as osteoporosis. Again, lab findings will have elevated PTH and elevated alk phos, and their calcium levels, although a lot of times the serum calcium will actually be normal, but you have to correlate that with their albumin levels. And the best way to actually truly assess a patient's calcium level is ionized calcium. And so that's the important lab to check. And then in terms of treatment, the most important thing for calcium is that it should be given in divided doses in order to replete any deficiency for the best absorption. And calcium citrate is the actual formulation that's preferred because it does not require gastric acid to be absorbed. And then the other common thing that we'll see is that patients are taking their calcium with their iron supplementation, and that is a no-go because calcium and iron compete for the same receptor. So they won't get absorption due to that. And then speaking of iron, so it is pretty prevalent, especially looking at 2 years out from any procedure. It is important for oxygen and electron transport. And it's important to know that iron deficiency can occur after any bariatric procedure, and it is pretty common preoperatively. And so iron is absorbed in the proximal small bowel. And so again, those patients that undergo some sort of malabsorptive procedure, BPD, DS, Roux-en-Y gastric bypass, are at higher risk. Also, if the patient has some sort of GI bleed, so marginal ulcer that's causing a GI bleed, or they have excess menstruation, those patients can also present with iron deficiencies. In addition, interestingly enough, if a patient has copper deficiency, they can also present with iron deficiency because copper helps with the absorption of iron from the gut. So clinical findings for these patients are they present with fatigue. Obviously, they have anemia on their labs, but also they present with the inability to regulate their body temperature. They complain of being cold all the time, and then they have white fingernail beds. Lab findings. So they will have low ferritin, elevated TIBC, and elevated transferrin. And the reason why those are elevated is because they have lots of stores, or they have lots of carriers, but they're empty. So the liver creates more transferrin protein in order to carry more iron, but all of those are empty. And then in terms of obviously their anemia profile will also be low. So low hematocrit, low hemoglobin, and low MCV. The treatment for iron deficiency is really in severe cases, it's iron infusions. Those patients should be connected with hematology so that they can get those iron infusions. And then also we have to make sure that the patients if they're taking a multivitamin with iron, that it's separated from their calcium, because again, iron and calcium, they compete for the same receptor. The other thing too is if the patient says that they're taking their iron and it's separated from their calcium, you can also add vitamin C as a supplementation, and that will assist in their absorption of the iron. Finally, in terms of vitamin deficiencies overall for bariatric patients post-op, I think the biggest thing is prevention. We have to recognize that it's pretty common. Patients can get inundated with all of the vitamins that are out there, and we can really try and make it pretty simple for the patient as much as possible. And recognize that they also have pre-op deficiencies. So preoperatively, starting them on a multivitamin is important. And then also making sure that they're taking their routine supplementation. So trying to make it simple. At our institution, we just do a multivitamin with iron, calcium chews that are separated throughout the day, and then a B complex. And so that way they don't have to take 6 different vitamins. And then we check their labs every 3 to 6 months based on our clinical suspicion and their complaints. And then we can adjust their vitamin intake based on what the lab values say. So thank you for your time. These are my references, and I will take any questions at the end.
Thank you so much for that overview. That's a lot to cover in 20 minutes. So last but not least is my partner and friend, Dr. Vishal Katari. He is a bariatric surgeon at the University of Nebraska in Omaha, and he will be talking about band and balloon complications.
Thank you, Dr. Haskins. Thank you, Dr. McBride. Thank you to SAGES for organizing this webinar. I'm going to share my talk here. Is it sharing okay? All right. So I'm going to be talking about the laparoscopic adjustable gastric band for the general surgeon, talking about a little bit about fills, complications, and how to explain one of these. And then I'm also going to talk a little bit about balloons, insertion, removal, and complications. So disclosures, I have nothing to disclose other than I haven't placed a laparoscopic band since 2016. I have removed probably about 50 to 100 in the last 7 or 10 years. And then when it comes to balloons, I've only trained in the Orbera balloon, but the concepts are pretty similar with all the systems. So we're going to talk about successful explant of the adjustable band, complications and management of the band, as well as the 3 FDA-approved gastric balloons here in the United States, and then management of these balloons. And the system that we use here at Nebraska, University of Nebraska to in place and remove and then kind of treat the patients with balloons. So just kind of an overview about the laparoscopic adjustable gastric band. We're doing it less and less over the last 10 years, at least in my practice. If you remember, essentially you're not creating any physiological change or resection to the stomach. It's not a sleeve, it's not a bypass. You're creating this kind of virtual pouch by placing a elastic band above at the GE junction or right below the GE junction to create like a virtual 15 ml pouch. And then it's connected to this port where you can adjust, you can inflate and deflate multiple times a year. And then on average, we see about 50% excess weight loss over a 2 to 3 year period. In terms of placement, I'm sure most of you are not placing these bands, although there are some people who still do. And I even for this talk reviewed and saw lots of people in my region who still place laparoscopic adjustable bands. Things to remember technically is, 4 or 5 ports, 2 working ports for the surgeon and assist and a camera, as well as a liver retractor, or some people use like a stitch or something now to expose the liver. Making this retrocolic tunnel, and then using either we used to call it a gold finger or a lap band passer. Sometimes you could just use a long long instrument and just pass the tunnel behind the G junction. And by doing so, then you can place the band, lock the band in place. Then you put 2 or 3 curl stitches to plicate the fundus over the band so the band doesn't move. And then you just attach the tubing up to the subcutaneous port. It's pretty straightforward. I'm sure, although there's some people still doing them, it's not being done that often. We'll talk more about the explant. Just in general, the trend in lap bands, looking at the MBS AQIP data, is a downward trend over, and this is older data, but by 2017, only about 2,000 band placements in the database compared to 4,000 in 2015. It's clearly headed in the downward direction, but there's still lots of bands out there and you're gonna have to manage them. So the 2 bands that I used to put in, the Realize band, which is no longer on the market, and the lap band, which since I started placing them has been bought by 3 different companies in the United States and has transferred different ownerships, but it's still there. This is the current version of the lap band in the United States, at least. The buckle and then the port, it's pretty straightforward. Lap band fills. So for most of you, this is going to be a situation where someone comes in, they ate something and got stuck, and they're miserable and the food is stuck above the band, so you need to deflate them. So you just need a Huber needle, and then you need to just kind of inject into the port. When you know you're through the port and you have good no resistance, you'll see the fluid come out and you'll be able to release all the fluid. In my practice, when we still actually do this, we have a band clinic, our mid-level providers or APPs do most of the fills, but we used to do these in my fellowship. You're trying to like fill to find that optimal sweet spot zone where they're not really hungry, and they're not looking for big meals, and they're also not completely obstructed where they have trouble swallowing or having terrible reflux or heartburn at night. You just want to get that nice sweet spot of like prolonged satiety, small meals with some satisfaction, and they're losing about a half pound to a pound a week. So, fluoroscopy, while it's not required when you're doing these, in my practice, I tend to use it because you can better visualize esophageal motility issues and avoid long-term complications, which you'll see about in the complication session. Initial adjustment, usually do 1 to 2 mLs for the lap band, 3 to 4 for the old Realize band. And then subsequently you add like a 0.5 to 1 ml per visit, and then you just have them swallow. I have them look at the fluoride films to see how well the contrast goes through, and just kind of modulate back and forth to see how things go. If a patient is losing about half a pound to a pound, kg per week rather, you probably don't need an adjustment. So we used to have all these patients who'd be like, I just want to lose more and more weight. Can I get more fills? But when you look at their weight trend, they're losing weight. You just tell them, at least right now, you don't need an adjustment. So what should a normal band look like? So here you can kind of see the port at the bottom of the screen, and then at the top, you can see the band at like a 45-degree angle. And the key is you don't see the inside of the band. If the band kind of flips downward and you see the inside, there's most likely been a slip or a migration to the blend, or the cheiroplasty has kind of fallen apart. And so there are going to be issues down the road. Accessing the port, you use one hand to stabilize the port and then use the Huber needle. I like to use like a three-way stopcock and have fluid so that I can kind of turn it on and off. And if you look at this short little video here from our floor suite, you can see the port. And then we're kind of visualizing, you put your hand down, one hand is stabilizing, put that Huber needle in there, and then we have a three-way stopcock. And then you're in the port with, you'll have that minimum resistance. You'll kind of feel this like softness when you go right into that squishy part of the port, and it will open up just fine. Some people sometimes would renew their initial fills with methylene blue, so that when you release the fluid or the stopcock, you'll see the blue. Not that many people do that anymore, but it's a possibility that you might see sometimes. What the swallow should kind of look like, essentially, as the contrast is going through, you want to be able to see there's some resistance or the pouch at the G junction, and then contrast kind of floating through and then into the stomach and then post pylorus. And as you give a little fluid or take a little fluid out, it should still be smooth. You don't want it to like completely obstruct and not be able to see fluid through it. You don't want the esophagus to super dilate up either. For a normal position, if you think the band is kind of at the G junction, it's probably in the right place. If it looks lower than that, it's probably malpositioned from a slip or something else going on. The big complications of the lap band leak, acute obstruction, the slip, which is kind of the biggest thing you're going to see with the lap band, is esophageal dilatation. This is most common in patients who had their band fills done at a center where they just did it in the clinic, and they just said, I didn't feel restrictions, so give me more fluid. And so they just came back over and over again for over years and getting fills. And so they dilated up their esophagus. It's almost like a pseudo stomach, and they don't feel much restriction, and they can still eat through it, and the food just kind of sits there. But that, of course, will cause severe esophageal dysmotility issues over the years. Other issues is that we see is a lap band erosion or a port flip or tubing disconnected or tubing that's leaking. So for early post-op band leak, the key is you're going to see contrast kind of pooling in a lateral position because it's going to be posterior. So if you see that kind of contrast pooling in the back, then you know that there's a leak. This is obviously a no-brainer. You go back to the OR, you take the band out, you repair the perforation. The more common things you're going to see, especially as a general surgeon in practice, you're going to see these slips, prolapses, esophageal dilatations, and there are different versions of it, posterior, anterior, or just kind of mushrooming or ballooning of the band itself. And so, how do you manage these? The simplest thing to do is just deflate all the fluid, and sometimes that will just slip the band back into position. Sometimes, the band will slip too much, or someone will have put too much fluid in it. And when you give them a swallow, you'll see that the contrast just sits above the band, kind of in this pseudo pouch, and you realize that there's way too much fluid, you got to remove it all, or the band is slipped down to the point that it's causing obstruction. So these are some images of a nasty band slip where there's actually acute gastric ischemia because the band had slipped so far down, all the stomach above just got ischemic, and this needed emergently to be removed. And usually, if you get it to it in time, it pinks up, and there's not much more you need to do. The prolapse or slip, like I said, if you can see the ring or that inside of the ring and that 45-degree angle slips, you probably have a prolapse of some kind. Like I said, you can deflate the band and sometimes it will reposition itself. But then as you start adding fluid, it may reposition. This is when you send them to a bariatric surgeon who might want to reposition it. Or in most cases now, they'll probably take it out and revise it to another operation. Again, this is a good picture of a decent prolapse where there's all this stomach. You really shouldn't see all the stomach above the band. And then the big thing that I talked about, esophageal dilatation, pseudoachalasia. I actually see this a lot more than you think from patients who had bands in for years, who just got their, like I said, their fills in at the bedside or in the clinic, and they just were basically told, can I add a little bit of fluid, and then they swallowed some water and they felt okay, and they went home. They did that for years, and then over time, their esophagus dilates, and they kind of get this pseudoachalasia picture. You can get manometry, and it will kind of look like a achalasia type picture. You know, if you take all the fluid out and take the band out, sometimes this will improve, but sometimes it's permanent. The port tube can flip, tube can leak, the tube can disconnect. This is a little hole in the rotated tubing that caused a leak, and so they lost all the restriction. So you can just replace that tubing. There's kits that can be used to do that. And then, of course, this is a CAT scan of a port flip. You know, sometimes it's just a mild flip where you can stabilize with your free hand when you're trying to access with the Huber needle and unflip it. Other times you just have to do a small procedure and unflip the band and resuture it to the anterior fascia. Erosions. This is a big thing that we see for patients who've had long-term bands in where they've had too much fluid. And essentially it can be harder to demonstrate on upper GI, but really obvious on EGD where you see this black eroded plastic thing when on your retroflexion view in the EGD. Sometimes on the upper GI, you'll see kind of the shadowing of the ring with the contrast around it. And that's a sign that there could be an erosion. There are basically, there are different ways it presents. Sometimes it presents as an infected port, and that infected port is tracking all the way back to the erosion. Other times it's just abdominal pain. Other times it's an incidental finding, like patients have erosions, they just don't even know it. Obviously, the easiest way to diagnose this is through an EGD. Sometimes you can see it on the CAT scan, sometimes on upper GI, occasionally on X-ray. You can, if it's greater than 50% of the band and buccal that has eroded through, you can sometimes remove these endoscopically, which I've been able to do if most of the band and buccal is through. And essentially you have to go in and place a wire around in between the lumen of the band and buccal itself. And then you bring it out through the mouth, use a stone crusher, ERCP stone crusher, and you crack it. And then you can, you'd have to open it up and cut the band tubing, and then you can remove the band from the inside. The other thing that you can do sometimes is place a stent between the eroded band and the esophagus, and just let that stent stay in place, and that will force the more and more erosion so that the band will erode all the way or halfway through or 75% through, and then you can endoscopically remove it. Otherwise, the only other way to remove the band is laparoscopically or either just taking it out from taking the capsule down and taking out the band and closing the eroded tunnel, or you could actually make a gastrotomy separately, take the band endoscopically out, and then close that gastrotomy as another way of doing it. But then now you have two potential areas of leak as opposed to one. An infected port sign is a bad sign for an eroded band. And so if there's a lot of fluid on a CT or there's a lot of cellulitis or erythema on the skin around the port site, you should be concerned. The lap band with GERD and hiatal hernias, a lot of the times the lap bands were too tight or they prolapse, and so they have reflux symptoms. You can treat these with PPIs and sucralfate, but most of the time, if it's really bad, you need to repair the hiatal hernia. Sometimes you have to remove fluid. Sometimes you have to either replace or revise the band. And this is a video of a band explant, just to kind of give you a conceptual idea. You can put your ports however you want. 2 working ports for the surgeon, 1 assist port and a camera. And then here you can see there's a Nathanson liver retractor. And as my senior partner, Dr. McBride, always likes to talk about, there's the old lap band has a little connecting tubing that actually goes at the port site. And sometimes it will fall into the abdomen and run all the way. In this video in particular, fell all the way in up to the band. So you really have to remove that portion of band tubing. Otherwise, it can be a retained foreign body, and you can have infections and other issues. So, once we get the little piece out, then we can attack the actual band removal itself. And the keys to a band removal is simple. If you can see the band or you see the capsule that's on top of the band that forms on these and stay on that, you will not hurt the stomach. So you really just want to follow that capsule all the way around 360 to try to free up the band until you can visualize the buccal. And then once you can see the buccal, then you can unbuckle it, or you can cut the buccal. And in this video, we actually cut the buccal, and then you can remove the band from the tunnel. And then after that, you can decide on whether or not you want to take the actual gastric plication down or not. And usually we take it down if we're going to revise the patient to another surgery, but most of the time you don't have to do that if you're just taking out in a kind of emergent situation or an urgent situation. that band tubing, and we're staying on top of it, and it's long. You're safe and you're not going to hurt the stomach. I don't know, my thing is freezing for fast forward a little bit. So here you can see the buckle free. Sorry, I got disconnected. I think my video did that. So I fast forwarded too much here. There you go. So that's the buckle. We're staying on the buckle here. And so now it's freeing up. And then at the top there where the scissors, it's going to cut the kind of connecting there. And then you just kind of cut that little area out. And that will free the band itself. And then you kind of pull that out through the tunnel, and then you just cut the tubing, and then you remove the port. And then you can decide to take down the gastroplasty, which is on the other side, on the back side there, if you'd like. But most of the time, if you're just doing this emergently, you don't need to do that. Or doing bariatrics, you know, can you revise right away? There's good data that says you can revise patients right away, although their risk of a leak or a complication is slightly higher, but it can be done. You know, in my practice, basically, if the band comes out smooth and the stomach doesn't look too inflamed, I'll proceed to a sleeve gastrectomy or a bypass. But if it looks inflamed, I tend to and then come back to do the revision a second time in 2 stages. So intragastric balloons. Again, I don't know how much experience you get as a general surgeon with this, other than sometimes someone may come in with one in, but we'll talk about the things that we do, at least here, and how we manage it. So why do we place intragastric balloons? You know, that's a good question. There are lots of people who are pro-con balloon, but I will tell you that, you know, patients, you know, they're risk averse in certain ways. The idea of changing their anatomy doesn't seem pleasant, or they don't think it's worth the risk at their current time in life. So they want other options. So these minimally invasive techniques for weight loss are key to help these individuals who are either afraid or think the risks are too high to get a Roux-en-Y or a lap sleeve. And so having these endoscopic tools are helpful. And so the balloon kind of fits in that range. In the United States, at least, you know, the FDA has approved the balloon for BMIs of 30 to 40. And you can use it off label above and below. There's some people who talk about using it as a bridge to bariatrics for the patients who have super high BMIs or super morbidly obese. But again, that's off label, at least in the United States. There are a slew of different balloons out there. This is an old slide, actually, because the companies have sold each other their balloons and it's changed a little bit. But the one I place is the Oberthrough balloon. I'll talk a little bit about that. And then there's a dual dumbbell balloon, and then there's the air-filled balloon, which is the Obalon balloon, and then there's a new balloon that is not yet approved in the United States, but should soon be, and I'm sure it's approved internationally, called the Lurion ellipse balloon, which is essentially a balloon where no endoscopy is needed. You just need fluoroscopy. You swallow a capsule. Under fluoro, we make sure the capsule's in the stomach. We fill the balloon up. We did the tubing kind of disconnects, and then after 6 months, the balloon dissolves and you pass it. You don't need any endoscopy. So that's kind of up and coming in the works. The history of the balloon, in fact, was proved in the 1980s. The theory was that this increased gastric distension will lead to satiety, delayed gastric emptying, and reduced caloric intake. The Garen's Edwards bubble was the first balloon. It filled only about 220 mLs. It was a self-sealing kind of valve. It did not work well. It was inferior to the bariatric surgeries of that time and had terrible side effect protocols. This is a picture of that balloon system, pretty archaic looking thing. And these are what the balloons look now. Indications are basically anyone who's had whose BMI is between 30 and 40, no previous gastric or bariatric surgery or any type of stomach surgery, no large hiatal hernias, no severe GERD, and are willing to comply with a 12-month intensive dietary program. The balloon is only in for 6 months and then the 6 months follow-up. The placement, essentially you do an endoscopy first, then you place the balloon. The endoscopy, the initial placement can be done under MAC anesthesia. The removal I recommend be done under general. It doesn't have to, but the stomach can get pretty gnarly with the balloon sitting in there. You can have some severe kind of delayed gastric emptying, so the risk of aspiration is a little bit higher. Once you watch the balloon, you fill it. There's a tubing that connects. You use a stopcock valve, fill it up to about 600, anywhere between 450 to 700. Most of the time I do about 600, 650, fill up the balloon, and then the tubing detaches. Then when you want to remove the bowl, or if you're in an emergent situation, there's a needle popping device with the suction system. You just kind of pop it in, suck out all the fluid. When the balloon kind of shrinks to kind of a tripod type position, then you can use a grasper and grab the balloon and just slowly pull it out, and so it doesn't get caught up in the GE junction. There were lots of trials. The Ribera pivotal trial in the United States showed basically at 6 months, compared to a control group of just dietary weight loss, you lost total body weight loss about 10% versus 3%. So that it showed enough efficacy that it was approved in the United States. They looked at endpoints of greater than 30% of excess weight loss. They got at least 15% and greater than 15% of excess weight loss compared to the control and a good portion of the group. In our program here, if you have severe GERD, or if you've had a large hiatal, or you've had a sleeve or a bypass, you're not a candidate. If you have severe history of gastric ulcers, you're not a candidate. If you have mild reflux, we tend to proceed and we just kind of control with the PPI. The pre-operative requirements, we treat this like any other bariatric procedure, so we get the whole bariatric panel, the upper GI and EGD. That's up to the program. We do both. So that we know we're not getting into an abnormal anatomy when we go to do the EGD. We set them up with a dietary visit so they know how to kind of do things. Prior to placement, we have them on start them on a PPI 7 days before. We try to do liquid diets with protein shakes for 5 days, and then 2 days of clears so that their stomach is completely empty. Then under MAC, you can place the balloon. We do a bunch of antiemetics. We have a whole protocol listed with Dramamine, Omeprazole, Levsin, amend, dexamethasone, all to try to prevent reflux and wheezing, nausea, feeling afterwards. This is a video of a placement of a balloon. Some people, again, first you do your endoscopy, then you place the balloon. After you make sure from the initial endoscopy, everything looks normal, you place the balloon, and then you watch it fill up. You can fill it up to about 600 is a good range. And you just slowly kind of watch as the balloon fills. And then there's a little connector. As you get closer to that 400, 500, 600 range, the connector will start to bow. And so once you feel like you've had enough, you just kind of give it a little pull or twist, and it will kind of detach itself, and then the balloon is free. So there, it's filling up now. Then the connector comes off once it's full. And then you do a final EGD. That's the balloon filled up, and then you can go behind it and retroflex to make sure it's sitting nicely. And that's the balloon sitting nicely behind. All right. Our post-op, the patients can be pretty miserable with nausea and abdominal pain, so we have a whole protocol using Levsin, Omeprazole. They're told to kind of lie in their left lateral decubitus position, not to lie flat for the first 24 hours because they can have reflux and some acid and stuff. We put methylene blue in ours so that if there's a leak and the urine turns green, we can know that we have to take it out. We give them a couple pain pills as well, and we do Tylenol. Every patient's different sensitivities wise. Some are miserable, some don't tolerate it pretty well. We then have them do PPIs for 80 milligrams for a week. Then we go down to 40, and then we go to like once a day. And we have a whole protocol. We don't into that, but they should stay off NSAIDs. They have tons of antiemetics, as they usually have problems with nausea afterwards. And then our diet progression is very similar to any bariatric progression. We start with liquids, then we go to soft mushy, then we start more solid foods. We tend to pastas, breads, and rices can sometimes stick to the balloon and cause bad breath, so it's something to know. So you want to, in over 6 months, it can get pretty nasty at times. I did a study looking at, patients going under the balloon over using the MBS-QIP as an analysis, and found that 10% total body weight loss we saw in the first 30 days, which is interesting, which meaning in the last 5 months or so after that it's placed, they're not losing as much waste, but they're just trying to kind of maintain their weight loss, in my opinion. I've looked at a bunch of studies, and it's clear that, the balloon over just a sham, you're going to lose a significant amount of weight, at least 10% on average over a 12-month period of time, versus diet alone. The complications, pain, nausea, reflux. Reflux is big. A lot of these patients, the 2 early removals I've had were because of severe reflux, and usually at 3 or 4 months, they were just like, I'm done. You can have bowel obstructions or perforations if the balloon leaks and my breath passes through, as well as a rare instance of death, but it's otherwise pretty safe. This is a picture of an ulcer from a balloon. And this is just a concept for, a couple of months ago, a patient came in with a balloon with abdominal pain, and they consulted us even though there was nothing wrong with the balloon. It's just an impressive concept to see what's in their stomach and what it looks like on a scan. So you realize why they're miserable with this thing in there at times, and it takes a while for them to get used to it. The dual balloon is a similar concept. You have 2 450 balloons. The idea thinking is that if one of these balloons pops, it's not going to migrate as much, and so there's less chance of migration. It's independently fills to avoid migration in case one of the balloon deflates, and this is what it looks like if they're both filled properly. 450 cc's each, and it kind of confirms to the stomach a little bit better than the traditional surround balloon. And the placement is very similar. You watch it go in, and you fill out both things separately, and then you pop it and you remove it with a snare. In this last picture with the snare, the reduced trial showed that it had pretty good results, equivalent to the Obera. We ended up seeing about 10% total body weight loss over time. I won't go through the data too much because we're running out of time. And then the last balloon that's available now is the swallow gas filled balloon, the Obalon. So they kind of test you to make sure you can swallow this giant capsule with the tubing to it. Then we put you under fluoro, and then we fill the balloon up with this is gas filled, and you do 1 balloon at a time over a 3-month period of time, and then you end up with 3 balloons, and then they follow you for 6 months, and the data for this is pretty good as well. And so I won't go through the data too much, but in the end, these are the 3 FDA approved balloons right now. Just so you know, the dual balloon was bought out by the Apollo, and they no longer make it available in the United States. I don't know if it's available internationally. And then the Obalon balloon was bought by Reshape, and so it's still available. And then we're waiting along for the FDA approval for the Allurian balloon, which will be completely not requiring no endoscopy, and then you can just use fluoroscopy, and then again you eliminate it on your own after 6 months. And thank you. If you have any questions, I think we're going to open up the session to talk.
We are. Thank you very much. So I actually have been keeping track of all of the questions since the beginning, and a lot of really great questions have come up in both the chat and the Q&A. So I'll kind of start with the first speaker, but several people wrote really great questions that I also think will be great to hear from all of the panelists, because they really asked sort of the how do you do it type questions. And I think if we poll the panelists, we'll actually find that there's multiple ways to do some of this. One of the questions, Dr. Chang, that was asked of you is you made a comment about not necessarily using an NG tube when someone comes in with an internal hernia. Could you clarify what you said about that? I mean, when do you think an NG tube is appropriate to be placed preoperatively to prevent an aspiration?
Yeah, that's I would say probably the main reason why people get nervous about it. If I was super concerned because the rulum looked very dilated, then I myself may place the NG tube in the operating room prior to induction, so that if there's any sort of resistance, anything like that, I would stop. And also I would probably stop a little bit more approximately a shorter distance than you would for a regular size stomach. These can also be placed under laparoscopic guidance once you are already in the operating room, if the rulum does remain looking very dilated after the surgery. But generally, again, a lot of these obstructions do involve the root limb, and perforations can occur with blind placement. And so it can definitely cause a lot more harm than potential benefit. And so I would recommend a little bit of cricoid pressure during induction rather than placement of an NG tube.
I would agree. I mean, if you've looked at your pre-op CT and you have a really dilated excluded stomach and a flat roux, then I don't see a lot of benefit from it. Encouraging your anesthesiologist to think about an RSI or even an awake fiber optic intubation are always good things to think about. Somebody else asked about trocar placement when you go back in for an internal hernia. And this is what I thought we could maybe poll the whole panel. How do you place your trocars when you go back in for an internal hernia?
So I generally place trocars in a similar position. I usually don't place the trocar that I use for my liver retractor. I use a snake, so it's a lateral right away unless I think I need it, because the area of action is going to be in the small bowel. I generally also place an extra 5mm trocar in the left abdomen somewhere so that it's easier for me to stand on the patient's patient's left side and access the TI and unwind everything that way. But especially, after you have to close the mesenteric defect or the Peterson's defect, you would already have your trocar set up like you would during the index operation.
Yeah, I think my trocars end up looking a lot like my gastric bypass trocars, 2 hands on the surgeon's side, a camera trocar, usually one for my first assistant. And then I would agree, usually one kind of more towards the left lower quadrant, so that once I'm in and I get the scope of the land, I can move to the patient's left side, find the TI, run retrograde. And then eventually you get to a point where running retrograde doesn't work. And so I end up handing the bowel to my first assistant with a very deliberate, this is distal, this is proximal. And then I run around to the other side of the table and I grab distal and proximal, and we all kind of shift our bodies looking northward again. And then you keep running proximal until it pops out. And then you go and you find where the defect was that it popped out of.
Correct. Yeah, definitely a little bit of dancing around during these cases.
And I know unfortunately, we didn't really have a talk on this. In one of your slides, you mentioned one of the other causes of small bowel obstruction is intussusception. And I think most of us are finding the longer we do this, intussusception, kind of raises its head. What do you feel when you see intussusception on CAT scans with people who are presenting with weird abdominal pain?
So
is it the source of the pain, or is it a red herring?
Exactly. That's a little bit tricky, just like, in the general population. If you see a intussusception, you ask yourself, is it transient? Is it not? But the patients do have a potential lead point because they have this jejunojejunectomy, which is an unnatural part of their small bowel anatomy. And if you see that classic target sign, and especially if you see non-passage of oral contrast, which hopefully was given at the time of the scan, that's an indication that that's probably causing a problem and is something that should be addressed. Depending on how the JJ was created, there are likely some risk factors for increased risk of developing an intussusception, and that's making a longer JJ, longer than 60mm, where a single staple load has been associated with that. But in those cases, when you go in, you would reduce the intussusception. If anything looks dusky, that should be resected. Depending on what exactly is involved, may dictate what you end up doing. If it's either the roux limb or the BP limb, you can consider plicating those two together to help prevent them from telescoping into the distal common channel. However, if it's the common channel that's intussuscepting with a very patulous JJ, then the whole thing may just need to be taken down and redone. And then, of course, the trickiest scenario is if you go in, the patient no longer has an intussusception and everything else looks stone cold normal. The question is, what do you do then? And in those cases, I generally tend to leave them alone because I don't want to cause a problem if they don't have one at the time of surgery, but everybody else may have a different opinion on that. I don't see, it's not the most common cause of obstruction by far, but definitely keeps on popping up every once in a while.
Right, I agree. I think it rarely causes obstruction, but I think the longer I do this, the more I find it is a source of chronic pain. So it's less likely to be the presenting thing to the emergency department that our colleagues who do more emergency general surgery see, or they'll end up discharging it and say, follow up in our clinic. And then they show up in clinic 2 weeks later and it's probably resolved itself, but now they're walking in with this CAT scan. And what do you do about it? So I often scan them again. And if it's still present and they're still in pain, I'll do a semi-elective exploration. And then, right, it's the eternal, do you pexy it or do you revise it? First time I tend to pexy it, second time I tend to revise it, but I don't know that any of us have the right answer. Any other thoughts from the panelists?
No, I mean, the only thing I sometimes do different is that when I see them in clinic, if I do a CT scan and the anastomosis is really dilated, then I'll revise it instead of pexying it. But otherwise, I do the same thing that you do. I'll pexy first. Hopefully that'll be fine. If they keep complaining with the same things, then revising.
Great.
Also, I just wanted to make a quick comment. For those surgeons that are out there that do robotic surgery. So as long as the patient is stable for the internal hernias, I will take those patients back and do it robotically. So I don't necessarily convert to lap to do that straight stick laparoscopy. So I use my same trocars that I would use for a bypass and then run the small bowel in the same direction that you mentioned. And it's usually, a lot of times it's the Peterson's defect and not usually the JJ defect for those patients who had a robotic bypass. So.
Right. So for those of you who are on the call, most robotic gastric bypass surgeons do more of an omega loop technique, whereas more straight stick laparoscopic surgeons, at least were initially trained to do more of a dividing the mesentery. So there's a little bit longer of a roux limb mesentery that then might have to get closed. But that's where it's always easier to explore your own patient for an internal hernia than someone else's patient for an internal hernia, because you know what to expect when you get in there, no doubt about it. Well, Dr. Landon, there were also several great questions about your talk and the difficult gastrojejunectomy. And you shared your protocol very nicely, but several people asked questions and I wanted to survey the panel. Does everybody leave a drain after a perforation? Does everyone get an upper GI before they feed them? Does everybody do an endoscopy on the table before, they leave at the end of the case?
I don't do drains unless it was kind of like a difficult one where like it leaked after my repair and then I had to fix it and then repatch it or something like that. Otherwise, if it looked pretty good, didn't bubble at all or nothing to concern, I usually don't leave drains. And I usually feed shortly after and usually don't do upper GI. I follow them more like clinically. If they're not tachycardic, don't have a white count, I feel pretty confident that everything should be fine. I do endoscopy usually a couple months after.
And do you do the same approach if it was not a gastric bypass patient and just a random perfed ulcer?
Yes.
Dr. Hassan?
So I always leave a drain. I scope them in the operating room. And I usually will, I'll actually do an upper GI the next day. And then if that's negative, I will feed them that next day. And then as long as the drain, that drain will stay about 5, I don't know, post like 1 week or so, and then we take it out in clinic. And I'll scope them a few months down the road to hopefully that has healed. If it's a duodenal ulcer, for sure, I will definitely, it depends on the size. So if it's small, then I will usually, same thing, drain, patch. But I usually don't leave a feeding tube in those patients because it's small. So unless it's huge, I won't leave a drain. I won't leave a feeding tube.
So I've had 3 pre-pyloric masses in about the last 18 months, and one of them perforated. So I'm going to make the argument that maybe every one of these in the excluded stomach should get a feeding tube so that you can dilate them up and scope them before you wash your hands of them, because every one of them has been a cancer for me in the last 18 months. So I'll just throw that out there.
That's fair.
Or do this open so you can get a biopsy at the time of your repair in your gram patch. So, but maybe I've just had a real bad string of bad luck. But if all I'd done is gram patch them and sewn them up, it would have been a lot longer before we realized that they had a pre-pyloric cancer, because every one of them ended up needing a Whipple. So I'll put that cautionary tale out there. Final question though for Dr. Landon, is there any role for working up Zollinger-Ellison for recurrent marginal ulcers?
Yeah, I think understanding the difference in etiology is important. Zollinger-Ellison is typically associated with gastrinomas, which we would see with pancreatic neuroendocrine tumors or in the duodenum. So very, very rare scenario, unlikely to occur. Common things being common, we're looking for smoking and NSAIDs and other sources. But certainly if you have a patient who has recalcitrant ulcers and you can't find a source, I guess you could order a gastrin level, but more than likely they would have had multiple ulcers previously and other signs and symptoms consistent with that process.
Excellent, thank you. Dr. Moran Atkins, at this point, do you think all hiatal hernias should be repaired in sleeve patients at the time of their index surgery?
Yeah, I try to be very aggressive at examining the hiatus at the time of the sleeve, and if there's anything that looks suspicious, I'll expose both for open up the hiatus and put a stitch if it's small. I've had sometimes where it's I'm surprised because I don't scope everybody pre-op, and I've been surprised sometimes, and it's a pretty big hiatal hernia, and I've had to either sort of decide this patient's probably not the ideal person for a sleeve, and I've had a couple of times where I've either spoken to the healthcare proxy or just woken up the patient and spoken about doing a gastric bypass instead of a sleeve. So.
And what's the panel's thought on these recommendations that have been coming out the last few years about that every sleeve should get an endoscopy at some interval to look for Barrett's?
I think it's pretty reasonable. The incidence of post-op reflux after a sleeve is increasing. I feel like a lot of the patients are coming back with reflux, and I feel like 20% is pretty high. So it would behoove us to at least document that there's nothing. I had a patient with us, who wanted a sleeve. She was 19 years old, but she had Barrett's. So it's so hard. So I think it really does behoove us to continue the discussion about it, but we also should be scoping them at some point, some interval. I don't know what that is, but we should do it.
I realize we are approaching time. For those of you who are going to be able to join us in Denver, I know there are several sessions in Denver dealing with this very important topic of both reflux of the preoperative bariatric patient, the appropriate workup, what should be done, as well as reflux in the post-bariatric patient. The final question, if they don't cut us off, Dr. Hassan, someone asked, I think this is really important, how do you deal with the patient who has real financial limitations to get their vitamins? What's the least expensive regimen you've been able to find to recommend for your patients?
Yeah, so the least expensive that I found is Flintstone vitamins. So take 2 Flintstone vitamins with iron, because it's usually you can get the Equate brand, which is the Walmart brand. So that's usually the most expensive, and we can tell them to take 2 of those. And then we can always titrate that based on their levels. But that's the cheapest one. I think one of the best ones, Celebrate, is really good, as well as ProCare Health, which is one of my favorites, just because it's once a day and it's not a big, huge chewable. So those are my favorites. But and then the companies, and talking to the companies, they will send you some coupons and things like that. So to make sure that you get those vitamins.
Yeah, we tend to recommend the ProCare Health just because if they buy a 90-day supply and they do the mail order, it ends up coming to $11 a month. And it's one capsule that has everything they need except their calcium. So it's got their B12, it's got their iron. And with one capsule a day, it seems to have the best compliance.
Exactly. Absolutely.
Well, I do think we're supposed to wind it down at 8 o'clock, unless I've got the time zone stuff wrong. We're supposed to be winding it down. Okay. Well, thank you everyone who joined us tonight, and hopefully we will see you all in Denver right around the corner. And thank you again to all our panelists for the amazing presentations. I hope we got to everyone's questions, or if we did not cover it, hopefully it will be covered in Denver. But see you all later. Thank you so much.
Thank you. Bye-bye.
Thank you.
Thank you so much.
Thank you.